I don't get excited about that stuff. All right. Did you start? We started. Okay. This is a significant announcement. I do not, I mean, nor would have I anticipated that anybody needed to you listen to that recording I sent to you. The problem, it's not a problem so much as it's just a matter of time. I mean, we do not have nearly as much time as I would like to cover everything I want to cover. So I elected, I'll tell you why, a self-study chapter, which is this chapter 11. I just loaded it on Blackboard. Effectively, this is about a little bit about epidemiology, a little bit about how diseases hurt you and things like that. Think we waited. A little bit about how diseases do their number, whether it's toxins, whether it's damaging tissue, how they hide, things called virulence factors. It's what I call, and you are familiar with this from other courses, a read the PowerPoint kind of presentation. It's okay. And all I do when I read the PowerPoint is amplify it with stuff from my experience and try to emphasize the points that are important. I mean, it's at least a minimum of 2, maybe even 3 pieces. So I put together a half an hour presentation to start. I'm not coming. What is something I said? I put together. I'm going to probably put together 3 little, maybe half an hour, 40-minute nuggets for you to listen to at your leisure, and to be able to do that. Because this is really, I like to do the antibiotic and antiviral chapter in front of you because I think you get more out of that. This one, you could listen to it and get as much out of it as watching me try to gesticulate. That's a word. Oh, you go. False. It's all right. I'm not even going to ask. Tell me later. So here's the good news. That's the bad news. You got to do a self-study chapter at home. Here's the good news for many of you. The exam number 3 will not be an in-class exam. You're doing it on Blackboard. What does that mean when you do it on Blackboard? Effectively, I'm not watching. It's not one of those respondus things where you can't, God forbid you use your computer like you wouldn't have a phone next to you when you're doing it. Finish it. Use whatever, you know what I mean. I have no problem with you. The problem is time. There's an hour time limit. It'll encompass this chapter, chapter 11, and effectively the antibiotic antiviral chapters, which are chapter 10 in Cowan and chapter 20 in Nestor. Got it? I sent you a study guide already. I was on top of my game. When we're going to do that, I do not know. We're going to find some mutually convenient range of time. And you guys done Blackboard exams? You must have. Yeah, okay. Basically, I create a log on, and there's a window of time. And once you open it, you can go back and forth checking all your answers, but you have the clock starts. It's what we call forced completion. In other words, once the clock starts, you have to have a good internet connection and all that good stuff. We did one to start last term because I had to be remember I had to be out of town. Oh no, that was the term before that. I apologize. That's when I had to be out of the country for my daughter's wedding. Got it? I will go over the gory details. It's not hard. Okay. So you get to do that one, and it should provide an opportunity to once again do well. And for those who already turned in the take-home exam, you saw some of the grades? Okay. So I got, not everything, they weren't due until today, so I just wanted to get a head start. I got to do something. There was no soccer this weekend. You know, the Premier League wasn't there. It was just, at least the Pirates finally won. Okay. Spill. Doing what? Oh, dear me. When's the MRI? Oh, God bless. Elevated, ISIT, the usual stuff. Oh, my gosh. Keep me in the loop, please. All right, let's get, I was to get started. Oh, I'm sorry to hear that. All right, so this is, that's not the one we're doing. We're going back to this. And I do want to start here for a quick review. What you will need, you should be familiar with, are these 4 mechanisms. Because it's a little bit about resistance, this very last piece. So, and I know there's a couple of questions on that on this exam that you'll be the third exam. So again, they make enzymes. We're very familiar with the penicillinase. It's probably the one you would need to know the most about. Again, this was where Mercer really came from, altering the potential target for a particular antibiotic. And then these are basically the same. You can either find ways not to take it in or ways to pump it out. So they're really, two sides of the same coin, so to speak. So that's, there's a lot of different things without going into a lot of gory details. There is a lot that goes on. And again, we looked at the mutations aspect of things. Spontaneous are always going to occur, but these are enormous populations that are there. And that's why in certain organisms and conditions that tend to be highly resistant for a variety of reasons, like tuberculosis, which we will come to ever so shortly, you're obligated to use more than one antibiotic. Sometimes you do it by choice and sometimes by requirement. Understand when who's ever prescribes, there's a protocol for these things. For instance, I worked with an infectious disease specialist, and my first wife ended up with hepatitis C positive. We consulted him. I mean, showing me what comes from the CDC every week about, okay, this is the current list of what you're supposed to use at this stage for different conditions. It's not elective. I mean, it's different. You're just choosing an antibiotic for a relatively simple infection. You get to complicated things. There's rules that are supposed to be followed again, and if you don't have a good reason. So if you ask the question when you're in a clinical environment, why are we doing it this way? Sometimes the answer is this is the way that it's almost mandatory to do this to be in compliance, unless there's specific things for exceptions. And I'm not going to go back into resistance plasmids and conjunction and transposition and conjugation and all that type of stuff. I made a note about this before. Enterococcus is interesting. Enterococci they're a cousin of streptococci. They're in the gut. Did you do throat cultures this week in lab? You did. Okay. Did you just put them on blood agar? Did you just wipe them out? Okay. You look for what are called hemolysis patterns. Streptococci, as a nutrient, gobble up red blood cells, whole red blood cells, either partially or totally. Some streptococci don't gobble it at all. This is one of the ones that does not gobble it. So it's a non-hemolytic kind of streptococci. Not that you have to know that. But this is a bad boy, and a lot of times this was one of the things when people were taking broad-spectrum antibiotics, before we really were that familiar with C. diff, we saw a lot of enterococci. And what they used, very interesting story, what they used was a lot of vancomycin. I know it doesn't work orally, but it didn't have to because this was in the lining of the colon more than anything else. And what happened, as you might guess over time, we developed something called VRE. So VRE stands for vancomycin resistant. Vanco resistant, and the E is enterococci. I just put enter. Okay. What happened in the meantime, back at the ranch, we had this vancomycin resistant enterococci. It's a diarrheal disease. It's all over the place. People can't stop going, so that means it gets on your skin. Okay, it kind of joins hands with staphylococcus. And then by way of a transposon, one of those jumping genes that can basically carry the vancomycin resistant staphylococcus, staphylococcus, and we started to develop things called Visa and Versa. And these are vanco resistant or vanco intermediate, IR and S like you did in the lab, Staph aureus. And now you're really dealing with a bear. And transferable, and that we think that is probably the underlying reason. And all of a sudden we have a potential severe killer in Staphylococcus aureus that we don't have a useful antibiotic for. That's why that pecking order that I spent so much time telling you about came to play. For many of you, because you're going to be in the clinical, you have to understand that's kind of why we have to do things in a certain way, and you do some differently if it's an outpatient population or if it's a hospital-based population. The trouble with the hospital-based population, that was in that initial thing I sent you that I recorded yesterday morning, is because you're dealing with compromised hosts. Sick people. Okay, their immune systems are bad, and you're going to run into it's a whole different subset of problems and much more difficult to treat. That's why you're going to see, that's why we do now almost all surgeries are outpatient surgeries, even very large surgeries. They're sending you home within 24 hours. My best buddy, his wife had to get a hip replacement. So, I mean, I said, well, how long are they going to keep her in? Oh, they're sending home. He said they're going to send her home within the day. Because you can see on an outpatient, before you admit somebody, you can be there for up to 24 hours, not more. 23 hours and 59 minutes. So basically, they keep you in a recovery area, effectively like an individual hospital room for that time, and then send them out. I said, what's going on? He goes, well, I'll get a motel room down here while, get a few nights, get a few hours sleep and come back and get her home. Hip replacement. Big surgery. Gives you an idea. These are the kinds of things. So you'll be dealing with, many of you, with this immediate post-operative environment. And those first 24 hours anybody will tell you, are critical. There's a whole subset of significant things. So bad things happen in the first 24 hours or so. If the surgery works out well, I will tell you from experience, after about 3 days, if there's not a big problem, things are going good. It's working. Problems show up early. So that's one example of a problem. Staph aureus. We talked about increasing resistance, healthcare associated. Now, all of those things. So obviously, over time, we talked endlessly about this. MRSA. Healthcare associated MRSA is much more resistant. We may have to go to Vanco or more, and particularly in nursing homes, but you have to go pretty aggressively to that. Again, there probably is a pecking order nowadays, which I'm unfamiliar with, but there'll be one. Now, Vanco intermediate and vancomycin resistant strains, and this is probably the origin of them. Where Staph aureus live? We all harbor it, by the way. If you work in a hospital, about twice a year, they will be able to cultivate MRSA out of your what? Where do staphylococcal organisms? You're not necessarily supposed to know. I thought maybe somebody did by chance. That's kind of like a throw out there question. Your nose is a common. It's not abnormal respiratory. It's like streptococcus in your throat, in your nose. Your respiratory system has a lot of these. It's where it is. We cough, we sneeze. It gets on our person. It gets on our hands. If you have an open sore or something, it gets there all the time. We'll go over this when we talk about skin-related diseases and respiratory-related diseases. That's why it's so easy. What happens in the hospital? Oh my God, if I have this. Fortunately for hospital employees, depending on the area, traditionally they will do nasal swabs. We'll do it for patients a lot, but they'll do nasal swabs. And if it turns out, that MSA stuff you're using in a lab, they'll plate it out and something like that. Put an antibiotic disc on, see if it's MRSA or not, whether it turns yellow, whether there's a zone, whether there's not. And at that point, they'll probably recommend to you to some type of topical agent. We use Bactroban, which is interestingly effective topically. I don't know if they still use it or if there's a more advanced form of it. And you could take it with a Q-tip or a fingertip and put it in your nose, both nostrils, a couple, 3 times a day. And that's very effective. I mean, you're not going to get sick from it, but you're more of a carrier. And that's what this chapter that you're going to hear and listen to and do self-study has a lot about what are called asymptomatic carriers. Like you can carry it to somebody. You don't have to be sick, but you can give it to them. Streptococcus pneumonia, the most common kind of bacterial pneumonia. When you get the flu, people don't die from influenza. People die from secondary bacterial pneumonia. The most common cause of this by far, Streptococcus pneumonia. That's the name of the organism. That's one of the ones you'd be testing for, I would think. Historically, extraordinarily easy to treat, but we are starting to see penicillin resistance. Okay. And as you can see, likely by it, remember, transformation from other streptococcal species. So again, one of those neat genetic mechanisms that has caused some degree of resistance to carry. About 1/3 to 1/2 of us harbor strep pneumonia normally in our respiratory system. A throat culture will identify. Just to give you an idea. So that's why. Now here, Enterobacteriaceae, fancy name for gut bacteria in the colon. Intrinsically, they're resistant because they are gram-negatives, nearly all of them. Outer membrane, they can produce beta-lactamases and frequently do. And what we are seeing is this: some further developed ability to produce ESBLs. I talked about them before. These are typically gram-negative rods that are extended spectrum beta-lactamase producers. Cephalosporins don't work. That aztreonam, which has a fair amount of side effects, but it's another cell wall antibiotic, different category than penicillin, but in the cell wall, can't work as well as the penicillins. And now carbapenem, another agent that was used historically. CRE strains found resistant to nearly all drugs. Carbapenems were the last resort for ESBLs, but the enzymes inactivate. So what we're dealing with, that's a superbug. The last time I read about anything, and I try to keep an eye on this stuff, was they were identifying some cases that they cultured out, but no, people were not ill. So they did find these in the laboratory, but they were not. They were coming from South America, is my recollection, where they were doing some of these studies. But fortunately, they were not demonstrating illness. So, I mean, they haven't got into a case where somebody died because they didn't necessarily have. They may have had inadequate antibiotic treatment, but they did have antibiotics that theoretically. TB. We'll get into TB with respiratory. It mutates relatively easily. And because in an active infection, tons and tons of these cells are forming inside a white blood cell. Tons. And then eventually that white blood cell bursts and spreads it. We'll get into how it works like this. So it requires combination therapy. They say 6 months. I'm telling you, most of the stuff I've read is a year. And we categorize it as multi-drug and extremely drug resistant. I'm not going to ask you about first-line drugs and blah, 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 and all this kind of stuff. And what's a first line or what's a second line. But to know how severe this is. And I mean, it's the third day in a row I'm seeing articles in a variety of like newspapers and websites that I take a look at, which are not necessarily medically based, talking about because they want to get clicks about, oh my God, if you go anywhere near TB, you're going to die immediately. But there is a major resurgence, as we talked about earlier. So it's such a valuable chapter for all this. And this, I don't want to get preachy. Read this to you. What you're within there, not only all of these, it's educate. I mean, all the things I have talked about in this, judicious and appropriate use of antibiotics, starting wide, narrowing your spectrum once you know what the heck it is, telling people, that's why we tell them, you have a 10-day supply. And don't tell me you don't know people who do this. Oh, little Johnny got amoxicillin for his year. Okay, well, 5 days it was better. I'll just save it in the medicine chest, and then next time little Johnny's got it, I'm just giving that. No, you're building resistance. The ones that maybe don't make the bad ones go away, but there's ones in there that after they survived after 5 days of the therapy, they're already starting to build resistance. That's the stupidity. You take them all the time unless you physically cannot. Okay? What I mean is it's making you so sick, then you call a doctor. And if it's like 9 days, I've done that. Say, hey, okay, forget the last day. Forget the last 2 days. We're good. I can't get out of the bathroom. I got the message. Okay? That's the kind of stuff that's so imperative to understand. And that's your end of it. My end of it and your end of it. Patience, instructions. Explain to them why. Why? Oh, I forgot my morning dose. I'll just take 2. Oh, I'll take 4 of these. If one's good, 4 have to be better. It doesn't work that way. It's all about maintaining blood levels in the bloodstream. So you have to understand the pharmacology and they'll acquaint you with this. Got it? Okay. And then this is what I was just telling you before. People do not. Antibiotics not indicated for colds, blah, 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 global impact, worldwide concern. You were aware that you can get antibiotics when you're out of the country fairly easily and certainly not illegally. Okay. I mean, don't tell anybody as he's working his way up in the Navy. But I can remember my son calling me from a tour when he was taking a little trip to Thailand when he was 15 years ago. Hey, Dad, what antibiotics you need? You need a couple of Z-Packs or anything like that? I'll get a few for you. What are you talking about? Oh, they got them here just in the store. I'll buy them and send them for you. Next time I get home, you'll have extra antibiotics just in case. Save your trip to the doctor. Oh. He is going to be a commander of a squadron of destroyers. You're in trouble. It's a good thing the statute of limitations is passed. It's okay. So that's part of the problem without prescription in many parts of the world, and people just use them. I'm not saying if they're used appropriately, I think it's a plus in a lot of ways. When it's used inappropriately, it's not. And then all of this, the use in animal feed, and this is one of the problems. We use look, it's business is business. So whether it's genetically modified crops, whether it's a bunch of antibiotics in our food chain that come in the early part of the food chain, we feel it to cattle, we feed it to poultry. That's when you look for those things, guaranteed antibiotic free. You've seen all the labels in the grocery store. If you haven't, walk around the grocery store, like looking at labels in the meat area. Exactly. The one that has the least stuff is the one you should be buying. Okay. It's more pricey. I understand that. It's about your budget. But please, I mean, that's the kind of thing you think about. If you're going to have something like that, reliable sourcing is very important. And so ends the sermon on antibiotics. Amen. Let's see. Antivirals. So you may recall we did in that last example, we're talking about how things work with regard to viruses. Okay, so for instance, okay, with the first thing they've got to adhere, then they got to uncoat, right? All that good stuff, ringing a bell. Then they replicate, then they assemble, then they pop out. Those are the major 5 steps. Okay, by understanding how viruses do business in our cells, we create antivirals. That's what that chart is all about. So if you take a good look at it, they take over the host cells. They don't have all of those things, all the things that are targeted by antibiotics. Okay, these are really, it's a little bit different. That's why the antibiotics don't work. When we use antibiotics for a viral infection, we're afraid, just like an influenza, a secondary bacterial infection. So the problem is there's really only 3 major categories of viruses that at one time, we're expanding it a little bit, that are useful. And those were herpes, HIV, and influenza. Now, maybe you could add hepatitis C to that package. Very, very limited being able to find effective tools. And I will tell you the most effective one is herpes. Okay, so lots of different things are there. So and the trouble is there are none that naturally occur. There's no antiviral antibiotics. These are all made in the laboratory. And all of them are only effective, not as a preventative, but only once you have the infection. Oh, so-and-so got a prescription for Valtrex. They said that'll keep herpes away, so I'll take them. It only is effective if you have the disease. All of them are like that. We do not have antiviral prophylaxis. Okay, that's what vaccines are about. When you talk about MMR, those are the way we prevent them is to generate antibodies that will fight them. So current options effective alone at specific type, none eliminate latent infections. You're only there. Eliminate is the appropriate term. When we get to that, Valtrex studies have shown that people who are prone to recurrent herpetic infections like that, okay, it is useful for stopping them from occurring. That's really where the science comes. So again, we now have agents to prevent entry. We haven't found anything. So this is a relatively new category for HIV. You don't have to memorize these. Uncoating. That was shedding that external aspect of it, shedding the capsid was the first target that was used. Very ineffective. It was used for influenza. They really aren't used today. The big area is here in the middle. Nucleic acid synthesis. That's where all what I call lookalike drugs, what we call analogs. They compete, competitive inhibition that are there. And then we have ones basically putting it together. This is a relatively new one for HIV, because remember, HIV actually joins the host cell's genetic material. It's RNA that's rewritten as DNA. The DNA then gets into your host white blood cell. Okay. So this is one of the ones that sort of been added to the typical three that were used for HIV. And then even drugs that do exit. So here, the ones that work in nucleic acid synthesis are down here. Right, and we'll kind of wander this through without me trying to read the full print. When we think about Tamiflu and Relenza, we call those basically they impact not just the assembly, but particularly the release. So neuraminidase inhibitors. You might remember, if not, if you're talking about influenza, you had those H's and the N's, so spikes. Review that when you rescue. The N spikes are about exiting, and that's where things like Tamiflu and Relenza work. They impact those markers. In doing so, are able to prevent it from exiting the cell. Like, remember, there are little ones that pop out. So it'll be useful, and you see it from the study guide, to look at a little nugget or two about each one of these. And so I'll try to highlight the ones that you need to know, that you will need to know for the exam that is forthcoming. Gee, we got a lot of people here. I'm so happy. Not that happy. It's okay. You may think that people of our age group don't go out and have fun. We, as an aside, I have to tell, we went to the Oaks Theater. Do you know where that is, anybody, in Oakmont? Well, Oakmont's not, and the reason you go there is you can stop at the Oakmont Bakery, which we did. And the Oaks Theater is one of these old movie theaters that they changed. There's a theater, the Palace Theater in Greensburg is like that. If you know where Zaley is, the Strand Theater is like that. Old theaters with decent seating capacity, they have a lot of different things. We went to see, and it was a fabulous show that's been in Vegas and all these other things at different venues, called 60s Mania. And let's tell, I was by no means the oldest person there. My wife and I felt young again. And people are up dancing to 60s music by this group, and they were fabulous. All sorts of neat videos and stuff like that. Reliving our Woodstock era days. Sure, not the first ones to originate this. Sorry, no techno music. Need to apply. If I had known you last year, I would have tried to wangle wedding invitations at my daughter's second wedding, the stateside version. Nevertheless, here we are. I mean, these are a bunch of names historically. Amantadine and rimantadine really not used, and a lot of problems with influenza medicines in general is you have to get them early on. If you've had the flu for 4 days and you find, well, you got the flu, we better give you something, likely it's not going to help. You're still going to have 4 or 5 more days before you start to feel better, despite the medicine. So we really don't use these two very much, and the names are so confusing. So you can look through all of this. In general, when they say nucleoside analogs, they're look-alike drugs for adenine, guanine, cytosine, uracil. And you can see it here. Okay, AZT, one of the original anti-HIV drugs in the earliest days, is a look-alike for thymine. Okay, here's the C. So there's a lot of different things that are there. Okay, and I'll try to go over them without you having to go crazy with the names and all of that stuff. And I'll try to be very specific with what you will need to know. And again, way down at the bottom, you'll definitely need to know these neuraminidase inhibitors. These are relatively effective. You do have to take them early, and they go by, and I never remember which one is which. They go by the trade names of Relenza and Tamiflu. And I'm sure you have heard of them, particularly during flu season. This is a somewhat older PowerPoint. And even though most of these are, again, HIV, influenza, and herpes, hepatitis C, there has been a real uptake in treating hepatitis C because it became a major concern. And we did not have that before. So the entry inhibitors are relatively new. I don't have anything specific that you have to know. The uncoating agents are very, very limited. I don't see that they are being used classically. I never had occasion to either use it or prescribe it or have anybody in my family get it. Not true for the Tamiflu and Relenza. I've taken those. The analogs, structurally similar A's, T's, G's, C's, U's, and they go through how it happens. Selective toxicity, since the viral encoded enzymes more likely than the host cell incorporate. Okay, only effective if the virus is active and replicating. What that means, again, is it's not a preventative. They are harsh. The basis of cancer chemotherapy, I've said this before, it's an opportunity to reiterate the point. Same deal. We use these kinds of look-alike drugs, and the ball game is to kill the cancer before it kills you, before it kills the good cells. Here, we're trying to attack the virus, but unfortunately, the virus is living in one of our cells. It's very hard. These agents will also damage us. So there are attendant risks, with one exception that I will get to, and why it's a good agent. Okay, most reserved for severe infections. Here's the exception, aciclovir. That is the category that Valtrex is in. Valtrex is called valaciclovir. Aciclovir and valaciclovir are available in oral forms. The aciclovir is also available for injection, meaning intravenous. When my daughter had viral meningitis, they had started her on this, let her go home, and because she appeared symptomatically better, but for whatever reason, and it's very hard to target, and there's no blame associated with this, that she had to go back in within about 24 to 48 hours, back in for another couple of days of the IV therapy. And basically, they just, for whatever reason, she didn't achieve the blood levels that were necessary, and then they sent her back home. She's fine, no problems. Okay. Why this is this? They treat herpes viruses with little harm because the virus itself activates it. That's the beauty of it. So why is it safe? Because if it enters a cell that does not have the virus, it basically has no tangible effect. If somebody's allergic to it, if they have significant side effects from it, that's a different story. Because those are somewhat, allergies and side effects are unpredictable. But the beauty is, for the most part, it's very effective agent that's there. And a lot of people have these on hand. It's a similar mechanism that sometimes will cause my wife's trigeminal neuralgia to flare because it involves the sensory nerve, which is the trigeminal nerve. And so a lot of times that occasionally, if she starts to get a cold sore for whatever reason, then the Valtrex helps and she doesn't get a flare of her trigeminal neuralgia or is severe. Just to give you some idea. And here's some other ones. This is relatively new. The ability to treat this respiratory disease of the newborn through RSV. Very, very limited resources. Now we have something. This was cytomegalo. Again, you're not going to have to know the names. I'll give you a laundry list of the names to be familiar with. And so all of those things, and a lot of times we have to use things in combination. Again, the accepted treatment now for people who are HIV positive, so they don't make that passageway into AIDS, is not 3, but 4 antivirals. Years ago, see if I can remember what they were. They had to have this, what they called the triple cocktail, very effective. Now we have a 4th member of the cocktail party. Okay, they had basically, remember, they're a backwards virus and they inhibit this enzyme. So they had reverse transcriptase inhibitors, protease inhibitors. When a lot of viruses use an enzyme called protease to carry with them, they make all those proteins in a long strand. They have, for instance, you might have spike proteins here, capsid here, and enzymes here. And what happens is, what protease does, an enzyme that separates it, so that they can then assemble and release the viruses. So protease inhibitors, and usually one of those nucleoside, nucleoside analog. And now I'm pretty sure they're using one of those integrase inhibitors as well. I'll have to look up what the pharmacology, you don't have to know it. But I'm just trying to give you an idea. When you attack particularly an extraordinarily dangerous and life-threatening virus like that and have a tremendous success, you hit it on all fronts. And this is in pill form. So, I mean, that's pretty unusual, but they have to take it every day. And there's a lot, and worldwide, there's a tremendous, particularly in equatorial Africa, meaning sub-Saharan Africa, where it's a third of the people are HIV positive, arguably. I mean, making these medications available is extraordinarily important. And it was really, we've been doing that since the second Bush administration, which was, if you recall, between like 2000, 2008, they put in those programs to make sure it was available, which are wonderful. And you go through these. I'm not knowing the names. I mean, you can go crazy. Integrase inhibitors, relatively new. Viral and release, that's the neuraminidase inhibitors for influenza. Very important that are there. Thank God. You are done with those antivirals. So, I mean, we'll get through this chapter. I thought we might have a little difficulty with it, but hopefully get this done today. And then I can start working on it. Once I get through with this, we're going to jump to the diseases. To me, that's the most important part. I like to arrange roughly a third, and we'll get about a third of the term in to do that. Because to me, I can give you some insight on what to look for, how they're treated. So clinically, it will be a benefit for this population. Okay. Eukaryotic pathogens, protozoans, fungi, worms. A little bit of New York East, never hurt anybody. Okay. There are cells, same ones, A and P. Okay. They have membrane-bound organelles like we do. It's very hard. There's always, period, always going to be side effects. You can't help it. Some are better than others. The easiest ones to understand are antifungal drugs. The whole idea of fungi have a cell wall, okay? But they have a membrane. Eukaryotic membranes like ours all have sterols. Remember that. We talked about that in AP1. Sterols. Sterols stabilize the membrane. Ours is cholesterol. In this population, in the fungal population, the drug of choice, all attack what stabilizes. They're called ergosterol, or if you will, ergosterol. I don't care how you do it, how you pronounce it. You need to know. Okay, there's multiple categories of these. So effectively, this wasn't true when I was in practice 50 years ago. We had other agents they tried to use. The problem with the other agents, side effects. Agents I prescribed, we don't prescribe anymore. There were too many problems. People couldn't stand going out in the sun. They had something called photophobia. It's like the sun. Without, I'm not talking about sunburn. Just being out there, it's like, oh my god, I can't take it. My skin start to crawl and itch and burn, even though it wasn't. That was some of them brought on immunological disorders. We didn't know about it, and then we stopped using them, obviously. So they target antifungal target aldosterone that we don't have. So all of these inhibit ergosterol in some way, shape, or form. They either come in topical, if they're very strong, oral, and sometimes injectable. They're not a panacea. So if you go to the store and get a fungal cream, okay, it's one of the creams that will probably be in one of these categories. So if you get standard generic antifungal cream, I'll show you as we go through the names, it's probably in this azoles category. Some of them are much better than others. You will see a lot of them if you're in the clinical world that are being prescribed to patients. I am sure they will cover this in pharm extensively. Pardon me. So I'm not going. You don't have to know categories and stuff like this, but let me explain them to you. There are ones over historically that worked on cell walls. This is the one we used to use for cell division. Oh my goodness. This was, and supposedly this was like, oh, give them this and magically good things will happen. I never had a lot of success with it. Okay. The best way I can describe it, historically, the polyenes, in very severe cases, when we get to respiratory, we will talk about we'll talk about San Joaquin Valley fever, now called Valley fever. Okay. The treatment, which is everywhere in the desert Southwest, amphotericin B, horrible side effects. Nystatin, so strong, we only used it in a topical sense. We used it for vaginal yeast infections and something you're going to encounter called thrush. You'll encounter both of them. You know what thrush is? Mm-hmm. So thrush, just for those that don't, about a third to a half of us have yeast commonly in our mouth, and maybe an equal proportion of that for gals have it vaginal. Okay? Normally, it is suppressed. Something we'll get to when we do genitourinary called lactobacillus. The acidity keeps that in check. And it's one of the reasons we see vaginal yeast infections. And so this was used topically very, very commonly because you can't do it internally. Thrush is something with immunosuppressive agents you can get in your mouth because it kills the good stuff. Happened to me multiple occasions. And what they used to use was nystatin. And they called it swish and spit out or swish and swallow because it was a limited amount. You swish around in your mouth and you spit it out. Now they don't even use it anymore. I'll tell you what they use in a second. But that's where it is. Nystatin is too toxic for systemic use. The little bit that you were squishing around in your mouth was low concentration. Didn't hurt people. But that was the treatment. I had that. And so, it's not pleasant at all, but that's when I was on immunosuppressive drugs. One of the reasons I stopped taking it. This is the category. For years, these were topical. Lotrimin or clotrimazole. When you get standard fungal cream, pharmacy, generic, it's going to be clotrimazole. Okay. Miconazole was an injectable agent they used for vaginal, Vagistat, something like that. It became like a little applicator that you could inject that way. This is a wonderful category, particularly this one. This is called diflucam, or diflucam, the way I would pronounce it. Diflucam, fluconazole. It is active orally and is extraordinarily effective. That's what they're trying to use. Statistically, they'll tell you that about 1 in 7 people have side effects. I had a list of diabetics who were very prone to yeast infections when we used antibiotics. I had like a little post-it note on their chart. It said, if you're giving antibiotics, basically, it said antibiotics with a star or some little way that I would have 2 prescriptions ready. One for the antibiotic, one for diflucam. 1 pill, 3 days. Basically, it's time release over 3 days. I never had a problem. I used it for years, 10 years. I'm not saying that there weren't problems with it, but I never had one. And you find that with doctors, one of the things we do is when we find something we like, we stay using. And another category is alleloamines. These were also in tablet form and in topical form. Those are the only ones we're using. I won't get it all done today, but this is the next time, and I'm getting close to stopping it here. This is the big player, that metronidazole. Metronidazole, you remember we talked about it for anaerobes. Most of the protozoans have anaerobic metabolism that we deal with constantly. So it is both an antibacterial and an antiprotozoan. The one I have to talk about that we won't get to is this, but quickly with the metronidazole. So whether it's C. diff as a bacteria, or it's one of those things you get from contaminated well water, like amoebic dysentery or amoebiasis, or giardia, which is even more common, the treatment of choice is metronidazole. And we're not done yet. Again, when we get to genitourinary diseases and we talk about trichomonas vaginalis, metronidazole. And we're not done yet there, because there's other conditions that we see in genitourinary diseases, what we would classify as non-sexually transmitted, that require metronidazole. I will leave you with that. Thank you very much. Look forward to my dictations. It'll give you, I'm sure you want to listen on when you're away for the weekend. Yes, we will be here Wednesday. I know you're excited. Restrain your joy. Tell the people who weren't here what they missed.